Hi, hello. My name is Jeffrey Chin. I'm an endocrinologist in Bethesda, Maryland. I'm going to be covering inpatient diabetes management. This is kind of a primer on what to do for inpatients. There are many ways of treating inpatient diabetes, and I'm hoping to provide kind of a framework to help guide your insulin decision making. One of the first things we should cover is a little bit about the pharmacokinetics of our insulin, the different insulins we have available to us. You can see on this graph, we have a couple curves. The first curve here, this is a rapid acting insulin. This is insulin like insulin aspart or insulin lispro. Once you inject it subcutaneously, it has an onset of action takes about 15 minutes to work. It peaks at about 1 hour, and it has a duration of about 4 hours. And you can see on this graph what that kind of looks like. Sometimes we use regular insulin. Regular insulin has a slower onset of action, about 30 minutes. It peaks about 2 to 4 hours after injection and lasts about 4 to 6 hours roughly on average. And those two are considered our two short-acting types of insulin. We have 3 long-acting insulins. One is NPH, one is Detamir, and one is Insulin Glargine. NPH, as you can see on this curve here, has kind of it still has a peak. It takes about 2 hours to take onset of action. It has a peak about 48 hours and a duration maybe about 12 to 16 hours on average. Insulin Detamir also takes about 2 hours to take effect, peaks maybe 3 to 8 hours-ish, and seems to last about 18-20 hours on average. And then Insulin Glargine, which is one of them, that's probably more commonly used. It has a peak of about 2 hours. It has an onset about 2 hours, should not have a real peak, and will last just about 20-24 hours on average. These onset of actions are important, especially when we're considering when to dose insulin per meal, and also when to dose your long-acting insulin. So, for instance, before a meal, it's ideal if you can inject a rapid-acting insulin about 15 minutes before you eat the meal. And when you're, for instance, transitioning off someone from an insulin drip onto subcutaneous insulin, you want to dose your insulin glargine, your long-acting insulin, at least 2 hours, maybe 2 to 4 hours before you stop the drip. And this will help prevent rebound hyperglycemia or worsening of their, for instance, ketoacidosis. Now, physiologically, this is what our body does, how much it produces insulin over time. So you can see that at all times we have a basal secretion of insulin, marked by this line over here. And then following each meal, our pancreas will create insulin. This will be a peak to cover the breakfast, this will be to cover lunch, and this will be to cover dinner. And this is the physiologic basis of why we use basal bolus insulin for most of our inpatients. And so basal bolus insulin means that you have a 1 or 2 times a day injection of a basal insulin, like insulin glargine, which will provide us this baseline insulin secretion. And then we have on average 3 or probably more doses of a rapid-acting insulin. Again, probably about 15 minutes before a meal to try to cover or try to mimic each of these peaks over here. So the majority of our inpatients, especially all of our type 1 diabetics, they definitely need to be on basal bolus insulin. And the majority of type 2 diabetics or patients who have significant inpatient hyperglycemia, they will be on a basal bolus insulin in the hospital. In general, we have 3 types of insulin requirements. We have a basal insulin requirement, we have nutritional insulin to cover our carbohydrate content in the meals, and we have a correction, or sometimes called a sliding scale insulin. And in general, people need to have all 3 to address hyperglycemia adequately. Okay, so when to treat diabetes or hyperglycemia in the hospital? So we consider a glucose level above 140 to be hyperglycemic in the hospital. And our threshold to start treatment is generally above 180. So, and we generally treat in the hospital to a goal about 140 to 180 for most patients. This is for non-pregnant adults, and occasionally people who have undergone certain cardiac surgeries, you may want to treat to a slightly lower or more tighter insulin or glucose targets. But for most non-pregnant adults, those are the 140 to 180 is our target range. Now, I'm going to try to cover a couple different scenarios. So say someone is in an ICU, intensive care unit. The insulin drip is probably the most practical and the most recommended way of addressing hyperglycemia in an intensive care unit. When you're deciding to transition someone off the insulin drip onto a subcutaneous regimen, there's one method I find very helpful to, try to calculate their insulin requirements. So I call it kind of the adjusted total daily dose method. So for the last about 6 hours or so while they're on the insulin drip, try to calculate an average hourly rate, multiply that by 24, and then you want to subtract about a third of that total daily dose. So you multiply it by 2/3. That's kind of like a safety factor to account for maybe stress in the intensive care unit. And that value should give you your adjusted total daily dose. And then what you can do from there is that you can split that value. Say you come up with a value of 40 units per day. You can deliver 20 of that unit as a basal insulin dose. You can give the other 20 units into 3 fixed doses to cover their meals. So, for instance, that would come out to about 6 units for right before breakfast, 6 for lunch, and 6 for dinner. And then on top of that, you still need to order some kind of a sliding scale or a correctional insulin. And one kind of rule of thumb that I've used is that if they're using less than 40 units per day of insulin, you generally want to use a light or low dose sliding scale. If they're using about 40 to 100 units per day of insulin, you generally want to use kind of a medium intensity sliding scale. And then more than 100, you probably want to use a high dose or high intensity sliding scale. Each hospital will have their own different insulin regimens, so definitely look at the order sets before you and if you need to, you can make adjustments. Now, say you're admitting someone directly to the wards, so you don't have the luxury of having insulin drip to try to calculate someone's total daily dose. So for the non-intensive care unit patient you're admitting and they have significant hyperglycemia, one way you can calculate or estimate their total daily dose is if by multiplying their weight by either a factor. So if someone's like severely underweight, frail, or have some very significant renal impairment, multiply their kilograms by 0.3 units per day, and that gives you your estimated total daily dose. If someone's more kind of a normal physiology, generally healthy, but for some reason has hyperglycemia, you can use 0.4, multiply that by their weight in kilograms, and gives you your total daily dose. Someone who's slightly more resistant, insulin resistant, maybe some obesity, 0.5 can be used. And someone who is definitely insulin resistant, maybe on glucocorticoids or significant obesity, you can multiply their weight in kilograms by 0.6 or even higher units per day. And that will give you your estimated total daily dose. And then you can do the splits, 50% basal, 50% nutritional with some kind of a sliding scale. And one thing I also want to mention is that usually day by day, you can start making your insulin adjustments based on the data from the previous 24 hours. In general, I like to kind of try to keep it sort of roughly 50% of the insulin is basal, 50% is bolus. But you can change either of these amounts daily by about plus or minus 10 to 20%. I don't like to make big drastic changes, but 10 to 20% up or down per day in these settings you can probably get some very good titrations. And how do you titrate your insulin, your long-acting insulin? Is you want to look at your fasting, your morning finger stick. If it's too high above target, you may want to increase the dose 10 to 20%. Or you say it's 100 or less fasting, you may want to decrease the dose 10 to 20%. And then how do you decide to adjust your bolus dosing? Is that your lunch finger stick gives you tells you what happened for your breakfast insulin dose, and then conversely, your dinner finger stick will tell you what happened during lunch, and your bedtime finger stick will tell you what happened for dinner. And so you can take those finger sticks to kind of adjust potentially your nutritional insulin dose, or you may even want to adjust your sliding scale correction a little bit. You can do that 10 to 20% increments per day. In general, as an inpatient, when they're on a subcutaneous regimen, you're going to check QAC and QHS. What happens when they're NPO? You're going to be checking finger sticks Q6, and some people would say you may want to reduce the basal dose, your long-acting insulin, by maybe 20% up to. It's obviously a clinician judgment. You can do that. And going back to the kind of this setup over here, you would still continue this potentially with a 20% reduction up to, and then you would still continue some kind of a correction or a sliding scale insulin, but you will hold the nutritional insulin. So for instance, if they're getting 6, 6, and 6 for breakfast, lunch, dinner, if they're NPO breakfast, lunch, dinner, you would hold this 6, 6, and 6, but you still dose if they need to their correctional insulin. So what to do about outpatient meds? So I like to think of it, so definitely patients who are type 1 diabetics admitted to the hospital, they have an absolute requirement to be on basal bolus insulin. If their glycemic control is pretty good at base coming into the hospital, but they're admitted for a non-glucose related issue, you can probably continue the outpatient insulin regimen. You may want to make, if you feel like there needs to be an adjustment, if they're not going to be eating a lot, or they're anorexic, you could reduce maybe the insulin doses maybe about 20% just to be kind of safe. That also holds true for type 2 diabetics who are also on insulin. You can probably continue the outpatient regimen if they're fairly well controlled. Now, if they're admitted for a hyperglycemic issue and they're significantly hyperglycemic coming into the hospital, you may want to increase the dose and adjust that way. Now, for the type 2 diabetic who is on non-insulin medications, you may actually want to, in general, if they are not in control, if they have some kind of a contraindication to any of their outpatient medications, may not be eating, significant physiologic changes, you still want to stop their non-insulin medications and put them on one of these basal bolus, probably using either this method or the insulin drip method. However, in the few patients who are type 2s not on insulin, if they are very well controlled coming into the hospital and they're not admitted for a glycemic issue, don't have a very significant physiological changes, you can cautiously consider continuing their outpatient regimen with some caveats. I'm going to go over some medications real quick. Metformin, well-known contraindication if their estimated GFR is less than 30. Usually it's contraindicated because of the lactic acidosis risk, so you gotta be very careful with that. Also to know, patients who have AKI is very common in a hospital, and sometimes a single serum creatinine doesn't give you the best estimate of your renal function, especially in that dynamic state. So be very cautious in metformin in the hospital. Secretagogues like sulfonylureas, meglitinides, they have a very unpredictable effect to your blood glucose. People can go low, especially if they're not eating enough in a hospital, or they have significant physiology issues, they're not clearing the medication, you can go get hypoglycemic. So in general, be cautious, maybe reduce the dose of sulfonylurea if you are going to continue that. SGLT2 inhibitors also have some concerning side effects, a potential for DKA, especially we call euglycemic DKA, patients who have a glucose less than 200, but they're in DKA. That is linked to type 2 diabetics who are taking SGLT2 inhibitors, and they usually have some kind of a acute illness or subacute illness that kind of provokes them into that state. So some physicians are telling their patients on SGLT2 inhibitors that they're feeling unwell, they should actually stop that medication. Less commonly used are the TZDs. There's a concern with fluid retention, heart failure risks, and if you have active liver disease, you shouldn't be using that medication. GLP-1 agonists, those are injection medications. A common side effect is nausea, so that can kind of complicate the hospital course. So if you're in that small population, if you're admitting as that type 2 well-controlled diabetic, not on insulin, and you're going to continue the outpatient regimen, just be very cautious, especially with some of their medications they're using. Now, I also want to transition to what I call kind of advanced calculations. So there are two factors I want to introduce. One is called the ISF, or insulin sensitivity factor, and one is called the ICR, or the insulin carbohydrate ratio. And how to calculate the ISF is you take the number 1800 divided by their total daily dose, and you get the ISF. And what that means is this is how much glucose, how many points of glucose that 1 unit of a rapid acting insulin will lower. So an example of a patient taking 50 units a day of insulin total, their ISF is going to come up to 36. You could build a custom sliding scale based on this value. So for instance, you can set a like a correctional sliding scale starting at 150 to 180, which is about 36. And that would mean you need to add 1 unit of Novolog or rapid acting insulin to their nutritional insulin to cover that. And you can add another 30, so 181 to 210, you add 2 units, so on and so forth. And so that is one way you can build a custom sliding scale based on the ISF. Another thing you want to do, this is for kind of more the patient who is definitely very savvy about counting carbs. A lot of times in a hospital, the menu will actually have the carb content of the item right next to it on the menu. So if a patient's ordering on a hospital menu, and they can add up all the carbohydrates, you can actually estimate how much insulin you need based on that. So it's a little more precise than just giving 6 units for lunch, breakfast, lunch, and dinner. How to come up with the ICR is you take the number 500, divide that by the total daily dose, and in the example of someone taking 50 units per day, that ratio is going to be 10. So 1 unit of Novolog will treat 10 grams of carbohydrates in general. So you can actually build kind of like a sliding scale for your carb intake. So if you're going to eat 30 grams of carbs, you're going to need about 3 units of a rapid acting insulin. 60 grams, you'll need about 6 units. And so to kind of put this all, kind of sum this all together, we have a hypothetical example of a patient who is normally taking about 50 units a day of insulin. And so that means, we'll say ideally he's probably on 25 units of a long-acting basal insulin once a day. He's about to eat lunch and he checked his finger stick and it was 212, and we'll say that his target is about 140. And so we know from his ISF, if you take 212 minus 140 and divide it by 36, he needs about 2 units of a rapid acting insulin to treat his hyperglycemia. And right before lunch, he's estimating he's going to eat 60 grams of carbs. And so we know from the ICR, that's going to give him, he's going to probably need about 6 units of a rapid acting insulin to cover just the meal. So you can add the 2 units up, you get 8. And so this means that right before lunch, he's going to need about 8 units, ideally 15 minutes before he eats, where he can take of a rapid acting insulin to cover the meal. And obviously you can adjust any of these values 10 to 20% in a day and if you need to, but this is one method of kind of estimating insulin requirement. And barring any questions, this is what I wanted to cover for today. I'm sure there's going to be a lot of questions. There's no one way of doing this, but this is a framework that I propose that may help people out in addressing inpatient hyperglycemia. All right, thank you.